Welcome to the chemistry lecture on electrolytes, part 1. I'm not going to be reading through the objectives, but instead we'll begin today with the introduction on slide 10. Electrolytes are substances that dissociate into ions when in solution, specifically water, and therefore can conduct electrical current, hence the name electrolytes. Generally speaking, the following two statements are true and applicable to our discussion of electrolytes. Anions are negatively charged ions and therefore are attracted to the positively charged electrode called the anode. Cations are positively charged ions and are therefore attracted to the negatively charged electrode called the cathode. The electrolytes that have the greatest significance to human health and can produce immediate effects if not in balance are sodium, potassium, chloride, phosphorus, which is present in the form of phosphate ions, magnesium, and sulfur, present in the form of sulfate ions. These electrolytes are present in both the intracellular and extracellular fluids and occur primarily as free ions, with the exception of calcium and magnesium. They serve a variety of functions, including enzyme activators, regulating osmotic pressure, and serving as pH buffers. We will discuss the significance and role of each individually. There are also electrolytes that we categorize as trace metals or trace elements. These are important as well, but are typically present in much lower concentrations. Deficiencies or excess concentrations of these electrolytes tend to produce effects that are slower to manifest and are more chronic in nature. These electrolytes include iron, both the ferrous and ferric states, copper, both the cuprous and cupric states, manganese, cobalt, chromium, trivalent is essential, but hexavalent is toxic, cadmium, zinc, bromide, and iodine. Unlike the major electrolytes, the trace elements occur mostly as conjugated metalloproteins. Since we're talking about substances that carry a charge, it should be noted that amino acids and proteins can also be categorized as electrolytes, though we typically don't discuss them in that context. The dietary requirements for the electrolytes is variable, but generally small. The human body has the ability to retain many of them when they are not being replenished in the diet. Some notable exceptions to this, though, are calcium, potassium, and phosphate. We are generally most concerned about electrolyte levels when they are out of balance. Therefore, it is important to have a basic understanding of conditions or circumstances that can lead to an imbalance. Three of the most common causes for the loss of electrolytes include vomiting, loss of chloride through loss of stomach acid, diarrhea, or loss of bicarbonate due to pancreatic secretions not being reabsorbed, and excessive sweating, loss of sodium and chloride present in sweat. This slide provides a fairly comprehensive list of the major functions of the electrolytes, excluding the trace elements. Osmotic pressure will determine the movement of water between plasma, interstitial fluid, and cells. It is regulated in large part due to the concentrations of intracellular and extracellular electrolytes. Blood pH is largely regulated by bicarbonate, potassium, and chloride ion concentrations. Muscle activity is affected by potassium, calcium, magnesium, and chloride. and the list goes on and on. A typical electrolyte panel will consist of at least 4 primary analytes: sodium, potassium, chloride, and total CO2, sometimes called TCO2. The CO2 content of plasma consists of 2 components: bicarbonate and carbonate. At the physiologic pH of blood, carbonate concentrations are around 1/1000th of that of bicarbonate, which is so insignificant that it is not included in the measurement. Most labs are able to perform electrolyte analysis on either serum or plasma. Heparin is the only acceptable anticoagulant for plasma samples used for electrolyte analysis. Though we do not perform an electrolyte panel on urine, urine can be accepted for sodium, potassium, and chloride analysis. Random urine samples are not the best to use for testing due to inconsistent results caused by diurnal variation, but they are commonly accepted for testing. Not surprisingly, there are a variety of situations that can contribute to error in electrolyte analysis, including hemolysis. Hemolysis will typically falsely increase both potassium and magnesium levels, though potassium is much more sensitive to hemolysis than magnesium. This is due to the fact that there are much higher concentrations of these electrolytes in the intracellular fluid versus plasma. Another contributing factor to error is the time to process samples. The longer blood cells are allowed to remain in contact with serum or plasma, the higher both potassium and magnesium levels will be. This is due to leakage of those ions from blood cells into the plasma. Ideally, blood samples should be spun and aliquoted within 30 minutes of collection. Another potential source of error can come from hemoconcentration caused by leaving the tourniquet on too long. Impeding the normal flow of blood can cause potassium, magnesium, and even calcium to leak into the plasma from the surrounding tissues. Lastly, some patients have a benign condition that causes transient hyperkalemia. This most often occurs when these patients pump their fist prior to and during venipuncture, causing falsely elevated levels of potassium. Due to the fact that many of these patients may be unaware of this condition, fist pumping is strongly discouraged as a means to cause venous distension. Next, let's switch our attention to methods of analysis. There are a variety of analytical methods that can be used to measure electrolytes. Some are currently used, while others are used as reference methods or simply have historic value. These include flame photometry, atomic absorption spectrophotometry, ion selective electrodes, coulometry, mercuric titration, and colorimetry. Flame photometry is an atomic emission method for the routine analysis of electrolytes, primarily sodium and potassium, as well as lithium and calcium. Quantitative analysis of these electrolytes is performed by measuring the light emitted from solutions containing the electrolyte. Patient samples are aspirated into the flame. The hot flame evaporates the solvent, in this case water, atomizes the metal, the electrolyte, and excites a valence electron to an upper state. Light is emitted at characteristic wavelengths for each metal as the electron returns to the ground state. A monochromator, or optical filter, is used to select the emission wavelength monitored for the specific electrolyte measured, since each electrolyte will emit light at a specific wavelength characteristic for that metal. Comparison of emission intensities of unknowns to to either that of standard solutions or to those of an internal standard allows quantitative analysis of the analyte in the sample solution. Most flame photometers incorporate an internal standard, typically lithium. A known amount of lithium is aspirated into the flame at the exact time the sample is introduced into the flame. In this way, any variations in flame intensity will be reflected in the recovery rate of lithium and used to correct the electrolyte measurement. For example, if only 95% of the lithium was recovered, then the electrolyte being measured should be multiplied by 1.05 to account for the 5% loss of recovery of the standard. As the name implies, atomic absorption spectrophotometry is a light absorption method for analysis of electrolytes. It is essentially the opposite of flame photometry, since the amount of light absorbed by the analyte is being measured instead of the amount of light emitted. Just as light is emitted at a specific wavelength for each element, light can also be absorbed at the same wavelength for that element. Atomic absorption spectrophotometry requires that a specific light source be used, called a hollow cathode lamp. Each element to be analyzed must have its own lamp, which consists of a filament composed of that specific element. When a sample containing a metal ion, such as magnesium, is introduced into the instrument, the sample passes through an atomizer that immediately converts the sample into a gas while ionizing the magnesium. In this ionized state, the magnesium ions will absorb light produced from a hollow cathode lamp, whose filament is pure magnesium. The amount of light not absorbed by the ionized magnesium in the sample then passes through a monochromator that selects for the wavelength specific for magnesium. This light then reaches the photodetector and is converted into an electrical signal corresponding to concentration. In this way, it is the amount of light transmitted that corresponds to concentration, but the method is called atomic absorption because it is based on an element absorbing light at a specific wavelength. Atomic absorption spectrophotometers are very large and cumbersome to use. Because of this, it is used for trace and heavy metals, metal analysis, in addition to being a reference method for magnesium and calcium methods. Our next method is ion-specific electrodes, or ISEs. This is the most common method used for routine analysis of electrolytes. An ion-specific electrode is a potentiometric method. Potentiometry is simply measuring a change in voltage. This is the same method used by pH electrodes, which is important to remember since we will be discussing that in the coming weeks with acid-base. At this time, I will give you a basic understanding of how ISEs work. Electrodes, such as ISEs, are composed of two half cells, connected by a salt bridge, and covered by a membrane that only allows a specific electrolyte to cross. Think of the salt bridge as a light switch, and the two half cells as the two wires attached to it. By turning the light switch on, the electrical circuit is complete, allowing electricity to flow between the two wires that are attached. With half-cell electrodes, the circuit is completed by immersing both cells into an electrolyte solution. Voltage is provided by the external reference electrode, which is orange in the slide. The salt bridge is the patient sample. The more electrolyte present in the sample, for example sodium, the more voltage is able to be conducted to the measuring electrode, which is green in the slide, by crossing the ion selective membrane covering the tip of the electrode. The difference in voltage measured between the standard solution containing a known amount of sodium and that of an unknown patient sample corresponds to the concentration of sodium in the patient sample. There are two distinct ways in which ISEs can be used to measure electrolytes. One is indirect and the other is direct. With indirect ISEs, the sample is diluted with a relatively large volume of diluent, followed by contact with the electrodes. The advantage of this method is that it ensures complete coverage of the electrodes while also diluting plasma proteins that can accumulate on the surface of the electrode membranes. This is the method most often used in large chemistry analyzers. With direct ISEs, the sample is not diluted and contacts the electrodes directly. This method is mainly used in blood gas analyzers and point-of-care testing. Next up is coulometry. Coulometric methods, such as the Kotlov method, are based on amperometry, in which changes in amps are measured instead of voltage. This method has important historical significance. However, it is still used today for performing sweat chloride measurements used in the screening for cystic fibrosis. Basically, the method involves immersing the anode, composed of a silver wire, and the cathode, typically a platinum wire, into a solution containing chloride ions, or the patient sample. When the test begins, two things occur. First, a timer starts. Second, and simultaneously, a constant and steady electrical current is applied to the anode, which generates silver ions at a constant rate. The silver ions generated combine with the chloride ions in the sample, preventing them from reaching the cathode. When there are no longer any chloride ions for the silver to bind with, there is a surge in electrical conductivity, or an increase in amperage, which signals the instrument to stop. Thus, time is proportional to chloride concentration. An increase in test time corresponds with an increase in chloride concentration. An example of a titration method used in clinical chemistry is the Shales-Shales mercuric titration method for chloride analysis. This method titrates the amount of chloride in the patient sample with mercury. Mercury will combine with chloride ions to form mercuric chloride. Just as with titration of an acid or a base, an indicator is required to signal when the endpoint has been reached. The indicator required using this procedure is diphenylcarbazone. Mercury is slowly and precisely added to a specific volume of patient sample to which diphenylcarbazone has been added. The exact volume of mercury added to the sample is monitored until the endpoint is reached, indicated by the retention of a color change from clear to blue. The concentration of chloride in the sample is calculated using the colorimetric formula, substituting milliliters of mercury for absorbency. Colorimetric methods are commonly used for the measurement of magnesium and calcium. The principle of the reaction is simple. Calcium or magnesium combines with a specific dye, resulting in the production of a colored complex that can be measured spectrophotometrically. Common dyes used for measuring magnesium include calmagite, formazine, methylthymol blue, and titan yellow. Common dyes used for measuring calcium include arsenizo 3, and orthocresylphthalein complexone, or CPC. It should be noted that for calcium measurements, calcium must first be removed from protein by an acidification step. Phosphate is also commonly measured using colorimetric methods. For example, phosphate in a patient sample will combine with a molybdate compound to produce phosphomolybdic acid, which in the presence of ferrous ammonia sulfate is reduced to phosphomolybdous acid, which turns a blue-green color. We're going to switch gears again and talk about osmolality. Water accounts for 40 to 70% of total body weight. Water balance and water movement between the extracellular and intracellular fluids is dictated by the osmolality of the different fluids. This is because osmolality is a measurement of the ion concentration in solution. As the ion concentration increases, so does the osmolality. Two processes are responsible for controlling the water balance between the intra and extracellular fluids. One is the movement of ions into and out of cells. This can occur due to passive diffusion along a concentration gradient or through active transport, such as the case with the sodium-potassium pump. The other process, which is by far more common and more important, is osmotic pressure, and by extension, oncotic pressure. Dissolved solutes contribute to the concentration gradient across a semipermeable membrane. The basis of osmosis is that water will cross a semipermeable membrane from a solution of low solute concentration towards a solution of higher solute concentration. As water moves into the solution of higher concentration, it becomes more dilute until the solute concentration, not fluid volume, across the membrane equilibrates. This principle is essential to understanding the causes of edema. There are two units of measurement that can be used to describe solute concentration: osmolality, which is the concentration of solutes per kilogram of water, and osmolarity, which is the concentration of solutes per liter of water. Osmolality is preferred to osmolarity because a liter is a measure of volume, and water will expand and contract depending on the temperature and therefore is variable. Osmolality is per kilogram of water, which is a constant. A kilogram is a kilogram at any temperature, unless we take it to the moon. Sodium is responsible for approximately 90% of the osmotic pressure of blood because sodium is the most abundant cation in the extracellular fluids. While we can measure osmolality directly from serum, plasma, and urine, it is also possible to calculate osmolality from measuring the sodium, glucose, and BUN, or blood urea nitrogen. The formula is given on this slide. It is important to note that the sodium concentration must be in millimoles per liter, and both the glucose and BUN values in milligrams per deciliter. The instrument used to measure osmolality is called an osmometer. Osmolality measurements are based on the colligative properties of the solution being measured. Colligative properties are those that affect the boiling point, freezing point, and vapor pressure of a solution. Freezing point depression is the most commonly used method in clinical laboratories. The freezing point of a liquid, or the solvent, is depressed when dissolved solutes are present, meaning that a solution has a lower freezing point than a pure solvent. Evaluating the freezing point depression of a sample can accurately measure the presence of all osmotically active substances in the sample. The reference range, or normal range, for serum osmolality is generally 275 to 295 milliosmoles per kilogram. The reference range for urine can vary somewhat between 50 and 1200 milliosmoles per kilogram. The ratio of serum to urine osmolality, though, should be about 1 to 3. The body regulates water balance through stimulating the thirst response and production of antidiuretic hormone, or ADH. The hypothalamus detects when plasma osmolality increases. The hypothalamus responds by stimulating the thirst response and stimulating the posterior pituitary gland to increase production of ADH. The thirst response stimulates increased water intake, which helps to lower the plasma osmolality. Increased ADH production stimulates the kidneys to increase water reabsorption, thus lowering the plasma osmolality. There are 4 processes that have a primary influence on the regulation of blood volume. They include the renin-angiotensin-aldosterone system, atrial natriuretic peptide, or ANP, antidiuretic hormone, or ADH, and changes in the glomerular filtration rate, or GFR. The renin-angiotensin-aldosterone system responds to decreases in blood pressure. I will explain it on the next slide. Atrial natriuretic peptide is produced by the atria of the heart in response to increased blood pressure. Its effects are directed towards the kidneys by stimulating increased excretion of sodium, and thus water, as well as increasing the GFR. You can refer to the previous slide for ADH activity. The juxtaglomerular apparatus is located near the afferent and efferent arterioles, as well as the distal convoluted tubule, or DCT. It is composed of 3 different types of cells. 1. The macula densa. 2. The extraglomerular mesangial cells. And 3. The juxtaglomerular cells. The juxtaglomerular cells sense low blood pressure and secrete renin, which activates angiotensinogen, synthesized by the liver, becoming activated angiotensin 1. Angiotensin 1, in turn, activates angiotensin 2, which signals the adrenal glands to secrete aldosterone. Aldosterone increases the reabsorption of sodium in the DCT. Water follows sodium, which increases blood volume, which in turn increases blood pressure. Sodium is the most abundant extracellular cation. It accounts for approximately 90% of all extracellular cations. In turn, though, there are low levels intracellularly. Sodium is transported as a free ion in plasma, and the primary source for replenishment is diet. Major functions of sodium include affecting plasma osmolality, regulating water movement between body compartments, or maintains hydration, protecting the kidneys from self-destruction by forming harmless salts with anions of strong acids, acid-base balance due to the bicarbonate sodium bicarbonate buffer, and nerve and muscle function. Normal range for serum and plasma is 135 to 145 millimoles per liter, or 135 to 145 milliequivalents per liter. Acceptable samples for analysis include serum, plasma, heparin only, and urine. Measurement is by ISE. Regulatory factors for sodium include the kidneys, the renin-angiotensin-aldosterone system, ADH, and thirst. In the kidneys, sodium is readily filtered by the glomerulus. In the PCT, about 60 to 75% is reabsorbed, while 20 to 30% is reabsorbed in the loop of Henle. Final reabsorption occurs in the DCT under the influence of aldosterone. Juxtamedullary nephrons are the ones close to the medulla of the kidney, or at least the ones that have the DCT and loop of Henle deep into the renal medulla, or the innermost part. The concentration gradient along the loop of Henle of these nephrons enable the kidneys to concentrate urine using a mechanism called countercurrent. In the descending limb of the loop of Henle, water passively exits into the medulla, but sodium and chloride don't. This causes the salt concentration to increase. In the ascending limb of the loop of Henle, sodium is actively transported out into the medulla. The concentration decreases the further up we go. This process maintains a horizontal gradient from descending limb to ascending limb. Hypernatremia can result from excessive sweating, fever, and dehydration resulting in water loss. Inability to respond to thirst, for example, infants. Diabetes insipidus, which is a lack of ADH. This only influences water reabsorption. Cushing's disease, or hyperadrenal glands, which causes increased aldosterone production. Excessive intake, ingested and from IV fluids. Renal failure, resulting in a decreased GFR. And cardiac failure, such as congestive heart failure. Hyponatremia can result from renal tubular disease, which causes decreased sodium reabsorption, metabolic acidosis, for example, diabetes mellitus. Sodium can be lost with organic acids in the urine. Addison's disease, or hypoadrenal glands, which causes a decreased production of aldosterone. Water intoxication, diuretics, or severe polyuria, profuse sweating, which can lead to sodium depletion, and GI loss through diarrhea, vomiting, and malabsorption. Potassium is the major intracellular cation, with only 2% found in the extracellular fluids. Even a small amount of contamination from cellular potassium may have drastic effects on plasma values. Potassium is transported as a free ion in the plasma and levels are maintained in the cells by the sodium-potassium ion pump. One of the functions of potassium is aiding muscle contraction via the sodium-potassium ion pump. When sodium is pumped into the cell and potassium is pumped out, this causes muscle excitation and contraction. The reverse process causes relaxation. Another role of potassium is in maintaining intracellular osmolality and fluid volume. In addition, it plays an important role in maintaining blood pH balance through its ability to be exchanged for hydrogen ions in the ultrafiltrate. The normal range for serum or plasma is generally 3.5 to 5.5 millimoles per liter or 3.5 to 5.5 milliequivalents per liter. Serum and plasma, heparin only, are common specimens to analyze. The cells must be separated ASAP to prevent cellular leakage into the serum or plasma, and hemolysis must be avoided. Urine can also be tested. Measurement is by ISE. The major regulator of potassium in the body are the kidneys. Potassium is readily filtered by the glomerulus, and almost all of it is reabsorbed in the PCT. It is re-excreted in the DCT in exchange for sodium under the influence of aldosterone. There is no protection from low serum potassium levels. Potassium will be secreted even if serum levels are low, as long as sodium is reabsorbed. Therefore, it must be ingested daily. If levels are too high, the kidneys will excrete the excess. Hyperkalemia can result from several conditions, including renal failure due to a decreased GFR, renal tubular disease where potassium is retained but sodium is lost, urinary obstruction, tissue damage, internal hemorrhage, and increased intake. Pseudohyperkalemia is an in vitro increase of potassium due to the lysis of RBCs, WBCs, and platelets during clotting. It is especially important in patients with elevated WBCs and platelets. When comparing serum and heparinized plasma potassium levels will be slightly lower. Hypokalemia can be caused by prolonged diarrhea, vomiting, or malabsorption, inadequate intake, rarely from diet, usually IV fluids without any potassium supplement, and diuretics. Chloride is the most abundant extracellular anion and is considered sodium's sidekick. Chloride levels tend to be inversely proportional to bicarbonate levels. Chloride only has a few major functions. These include responsible for plasma osmolality and thus water balance together with sodium, maintaining blood volume together with sodium, and maintaining acid-base neutrality through a process called the chloride shift. But more on that later though. The normal range for serum and plasma is 98 to 108 millimoles per liter or 98 to 108 milliequivalents per liter. Sample types include serum, plasma, again heparin only, sweat for cystic fibrosis screening, and urine. Serum and plasma samples must be separated from the cells ASAP. Measurement is by ISE. Chloride is primarily regulated by the kidneys, the diet, and sweat glands. In the kidneys, chloride is filtered by the glomerulus. passively reabsorbed in the PCT and loop of Henle, along with sodium, and passively reabsorbed in the DCT, along with sodium, under the influence of aldosterone. As for the sweat glands, excessive sweating may stimulate aldosterone that acts on sweat glands to conserve both sodium and chloride. Hyperchloremia can be caused by dehydration, a relative increase due to loss of fluid volume, diabetes insipidus, also water loss only, renal failure due to a decreased GFR, decreased cardiac perfusion, like congestive heart failure, and excessive intake through the diet or IV fluids. Hypokalemia can be caused by GI loss, such as diarrhea, vomiting, and malabsorption, excessive sweating, chronic pyelonephritis due to lack of reabsorption, aldosterone deficiency, and diabetic acidosis, as sodium is lost with organic acids.